Hi folks, my name's Drew Henderson. I'm one of the PGY1 orthopedics residents, and I will be giving a talk on compartment syndrome. So to get into the concept and define what compartment syndrome is, it is a disease of tissue malperfusion. In the case of limbs, and I will point out you can get compartment syndrome elsewhere in the body, but in the case of limb, this can even be limb-threatening disease, depending on the extent of ischemia you get. And there's a definition there at the second bullet point, which I won't bore you with reading, but essentially you get pressures high enough in your osteofascial compartments that blood flow from the arterial side can't get into tissue and can't support it. Accordingly, you get muscle ischemia and ultimately death of the tissue itself. So in mathematical terms, perfusion pressure is equal to the difference between your mean arterial pressure and the compartment pressure, meaning the pressure at which blood flows in. You subtract out the pressure imposed by the compartment itself, and that's the net value, or the perfusion pressure. It's very analogous to the cerebral perfusion pressure I'm sure you've run into in other lectures. So accordingly, when your compartment pressure increases for any of a number of reasons we'll discuss, your perfusion pressure in that tissue goes down. Ultimately, if this gets severe enough, you get hypoxia, and you can ultimately get muscle ischemia and loss of the limb. Now, what causes compartment syndromes? Obviously, multiple things can. I can tell you that from our orthopedics perspective, we get many consults regarding this. The most common consults regarding it that we run into are related to acute fractures, particularly fractures of the tibia and fibula in your lower extremity. Tight external dressing, so this can be an iatrogenic injury. If you've put on your cast too tight in order to set a closed fracture, you can strangulate the tissue underneath or cause a compartment syndrome, particularly in the case of post-traumatic swelling. The other place we run into it is in chemotherapy, where you do limb perfusion. You can get a reperfusion injury to the limb that can lead to compartment syndrome. And then there's obviously others on this slide. One question attendings always like to ask regarding compartment syndrome to pimp the medical student is, can you get a compartment syndrome if your fracture is open? In principle, it sounds like you couldn't, but the point of the question is that yes, you can. So while one or more of the compartments in the extremity may in fact be open as a result of the injury mechanism, it doesn't mean that there's no possibility of compartment syndrome, because the other compartments therein can still be closed and can still be swollen. So the two most common places you think about compartment syndrome in the extremity are your lower leg, pictured on the left, and the forearm, pictured on the right. So these are both axial cuts through each extremity. Obviously, the two bones in the lower leg, you're seeing the tibia on your right and the fibula on your left, and then there are four fascial compartments contained within this segment of the limb. There's an anterior compartment, which contains your foot dorsiflexors. There's a lateral compartment, and then there's two posterior compartments, a superficial and a deep, which predominantly relates to your ability to plantar flex the ankle and flex your toes. These are contained within septal planes, and there are layers of fascia that can break these into individualized compartments. In the forearm, alternatively, you've got a total of three compartments. You've got a volar compartment, or when the hand's in the anatomic position, that's your anterior compartment. It contains your hand and finger flexors. You've got a dorsal compartment on the backside, or posteriorly, that contains the extensors. And then you've got a third compartment called the mobile wad, which contains those three muscles represented on the far right-hand side, the extensor carpi radialis longus and brevis, and the brachioradialis. At the bottom of the screen, you'll see the fact that there are other locations in the extremities that you can get a compartment syndrome. So how do we diagnose a compartment syndrome? In short, even though we focus on the pressures and it would seem to be a numerical diagnosis, it's a clinical diagnosis. Compartment syndrome is primarily clinical. So the symptoms, the classic answer you'll see in your textbooks and your USMLE review text is the 6 Ps, meaning pain, pressure, pulselessness, paralysis, paresthesia, and pallor. As you can imagine, in the injured extremity, you can get these symptoms for a lot of reasons. So the shorter version is the following. If you get pain out of proportion to the injury, which is aggravated by passive stretch of the muscle, you start thinking about compartment syndrome. If you have somebody who's in no pain, with rare exceptions, they likely don't have a compartment syndrome. So even though their extremity is swollen and tight, and man, it seems like that cast is on very tight, if they're not in much pain, it's unlikely that they're putting their tissues at risk, because doing so is a painful entity. So when we get consulted on a possible compartment syndrome, one of the first things we do is ask them to relax and passively stretch their ankle up and down and see whether or not that makes them jump off the bed. Unfortunately, if it does, we worry much more about compartment syndrome. Cautions regarding my comments on the exam relate to what you see pictured here. In sedated patients, well, that goes without saying. In patients who have had extremity blocks, and in orthopedic surgery, this is actually much more common over the last several years. They work great for analgesia, but they can mask a compartment syndrome. Similarly, patients who have too much narcotics on board, and patients who have other injuries that are potentially equally painful, it's difficult to clinically describe a compartment syndrome. Accordingly, you need a firmer way to diagnose compartment syndrome, because ultimately this is a surgical emergency and you don't want to take somebody to the OR because you suspect they may have, this compartment syndrome. And so what we do is we measure pressures in the compartment. So we use this Stryker needle. They can be found both in the operating room and several other places in any hospital. And you measure the pressure through a very complex mechanism, which we won't go into, but you get a feel for how many millimeters of mercury of pressure contained within a compartment. Similarly, you can obtain a current blood pressure, and you compare the two, simply like we discussed on one of the previous slides. Importantly, you have to measure all compartments, so if you're in the lower leg, you don't just stick somebody anteriorly and assume that all is well if that number is low. You need to attain pressure readings for all 4 compartments, and ideally, you attain them from multiple positions within the compartment to get a better feel for things. Now, obviously, sticking somebody with a very large needle is a painful thing, so there's a sort of a risk-benefit attached to this, but if you're worried about compartment syndrome, it's far better to make sure you get it right. Compartment syndrome is diagnosed when your pressure is within 20 millimeters of your diastolic or 30 millimeters of mercury of your MAP. This slide is a discussion of the fact that in the acute fracture setting, the distance you measure from your fracture site, so from where the bone is actually broken, does have an impact on the pressure you're going to see. And the point being that if you really want to get your maximal pressure, give yourself the highest likelihood of diagnosing a compartment syndrome, if it is truly there, you want to be close to your fracture site. If, however, you have either opted to, based on clinical exam, not stick their compartments, or if you think their compartment readings are reassuring, meaning they're not within those thresholds, they're not up to within 20 millimeters of their diastolic pressure, typically the recommended course as you watch a patient is to see them every 3 to 4 hours, or in the case of hospitals where this is possible, have the orthopedics team do it, or have somebody dependably see this patient and do a repeat exam and see if they clinically evolve. Do they get better? Is their exam more concerning? Do you need to stick their compartments again? But this is not a patient you see overnight as the on-call intern, say, okay, their pressure was only 30, and then hope everything's okay till the morning. This requires a very high clinical index of suspicion. Now, you will see a lot of physicians order CK, or creatine kinase levels. Now, obviously, CK is something released by muscle cell when it dies, or when it's injured. The point I'm trying to make at the bottom of this slide is that CK is neither a sensitive nor a specific marker of compartment syndrome. In extremity trauma, CK levels can be elevated for many other reasons than compartment syndrome. Similarly, you can have an evolving compartment syndrome and not necessarily have an elevated CK simply because it hasn't had time to leak out into your global circulation. The one place you really do have utility in following a CK value is after your fasciotomy, and we'll talk about that in a moment, to ensure that they trend down and ensure that you've halted the spread of muscle ischemia. If they don't, you need to be worried, or at the very least have a heightened suspicion for the fact that your fascial release may not be complete. So suppose you've got somebody, you've stuck their compartments, they have a diastolic pressure of 50, and they have a compartment pressure of 85. Well, by that equation we looked at on the first slide, there's no way they're actively perfusing that compartment. So they're at risk of ischemia, if not undergoing frank ischemia. What do? So the first step is to remove your iatrogenic causes, meaning if they have a cast, you need to cut the cast. At the very least, open it up some. At the most, take it completely off and worry about that down the road. You want to elevate your extremity to the level of, but not above, the level of the heart. The reason being you want to maximize your perfusion, but at the same time you don't want to take away from that perfusion pressure coming from your heart. Big picture though, this is our one level 1 surgical issue we see in orthopedics. Open fractures are one thing, bad polytraumas are another, but that which really requires us to post a case level 1 to the operating room is a documented compartment syndrome. We're pretty aggressive about doing so because it's the one instance we run into in orthopedics where time really is tissue. It's very serious diagnosis, and it often, acting quickly, can save a patient's extremity. The treatment once you get into the operating room is a fasciotomy. Again, if I've just spent several minutes describing the number of compartments contained within an extremity, well, you can imagine that to do a proper fasciotomy means opening all compartments in that extremity segment extensively. So this picture, while not intended to be gross, does point out the point that this is not a minimally invasive procedure. You want to open the leg from stem to stern if necessary to fully release the fascial compartment. If you miss it and lead to more ischemia, you've made a mistake. Typically in the OR, we'll cover these with a wound vac and intend to re-explore them in 24 to 48 hours and evaluate how much more muscle has necrosed. In the case of acute fracture, you want to stabilize the fracture typically with an external fixator to temporize the situation. Now, what happens if compartment syndrome does in fact evolve? Well, this is just a little bit of data, and apologize for the amount of text on the slide, regarding how quickly tissues respond to ischemia. So, peripheral nerves, you get reversible nerve injury within 4 hours. You get irreversible injury after 8 hours. Skeletal muscle, you can make it 3 to 4 hours again without irreversible damage, but once you get to 6, and most definitely once you get to 8 hours without sufficient blood flow, that muscle will start to die. An important point is that many compartment syndromes, and the most recent literature points to the number 10%, are in fact mixed. And if you miss a compartment syndrome and that muscle dies, that extremity likely gets contracted. This is what you always see on the board exams with what's called a Volkmann's contracture when you get a missed upper extremity compartment syndrome. If you have missed it by more than 24 to 48 hours, it's actually a contraindication for surgical intervention. You've missed your window. Unfortunately for that patient, the tissue you are worried about saving had its fate determined. It will not survive. Accordingly, there's nothing to be gained and a lot to be lost by taking them to the operating room. So in short, compartment syndrome is our true orthopedic extremity emergency. It is premised on lack of blood flow because of increased tissue pressure preventing blood flow into an extremity compartment. While the definition listed here is a numerical one, the diagnosis of compartment syndrome is primarily clinical. And if diagnosed, treatment of a compartment syndrome is emergent, full, multi-compartment fasciotomy. Thanks very much.